Welcome to the session on managing challenging symptoms. My name is Amanda Howell and I'll be your session chair. Excuse my voice, I don't have germs, just lung issues like most of you would understand. It's my pleasure today to introduce our speaker for the session, Associate Professor Natasha Smallwood. Natasha is a consultant respiratory physician at the Alfred Hospital, head of a chronic respiratory disease research group and associate professor at Monash University. As you can see there, that's probably only a snippet, I'm sure, of what Natasha has achieved. If you're like me and you like to Google and know what's happening and people you're going to meet, Natasha has wide and varied research papers and publications available. Some I've had a sneaky peek at, and as you can see, is a wealth of knowledge. She will be presenting today on managing challenging symptoms, and please join me in welcoming Natasha today.
Thank you very much for that kind introduction. So Chris told you about having worked at the Brompton. I also worked at the Brompton, but I'm English, so I was one of the English doctors working at the Brompton. I was there 22 years ago working for Athol Wells, and I fell in love with and married one of those Australian registrars. So one of those registrars from Melbourne became my husband, and I moved to this country 21 years ago. So interstitial lung disease is actually part of my love story, which is a bit strange. So I do have some disclosures, but they're not particularly relevant. So the purpose of my talk today is really to talk about holistic care and how we can manage challenging symptoms for all of you guys and how we can do it better. So as Chris highlighted, the main symptoms that most people experience are breathlessness, cough, and fatigue. And that's kind of like the holy triad in most respiratory illnesses. So that's what we see, whether it's interstitial lung disease or people who come and see me for other issues. Those are the three symptoms that are very challenging to deal with. There's also the issue of side effects from antifibrotics, which Chris touched on, and which I will also briefly touch on. But the problem with most illnesses, it's not just the physical effects, it is the psychological effects. So most people who come and see me will have some degree of anxiety or depression, and often it is about exploring that, about frustration, about sadness, about what's changed, and understanding what those impacts are, because they're actually really critical to deal with. But it's not just psychological. We know there are social impacts, and many people who come and see me with severe disease are very socially isolated, and all of that can impact quality of life. So it sounds quite depressing, but the point is there are things that we can do, but you have to find someone who's going to help you to deal with these challenging symptoms. The one thing I would like to stress, which is a little sad, is that symptom management has been a very neglected area of research in interstitial lung disease and actually in most respiratory illnesses. It hasn't been particularly looked at, but that is changing. So I lead some of those clinical trials. I've got collaborators around the world. So there is actually a growing research repository regarding what is changing for how we can better manage symptoms. So typically when we think about how to deal with an illness, and I don't really expect you to read what's on this slide. This is a slide I was using to teach some colleagues yesterday. But as Chris was saying as well, we take a disease-directed approach first. So we want to work out what type of interstitial lung disease you have. We want to work out what your other problems are and how they contribute to your symptoms, and we want to treat those first. So that is our target for how we deal with these illnesses. The thing is, though, many people are still symptomatic despite what we've done. And in fact, in pulmonary fibrosis, the antibiotics really don't make any difference to your symptoms, and I can make you feel quite miserable with the drugs. So I often make you feel worse than when you came to see me. So that means we really do need to think about symptoms, and we tend to take a stepwise approach. So we take a drug-free approach, and then in some instances, there are medications we can use for symptoms, which I will talk to you about. I guess one of the things that I hear commonly, and to put this into context, so I'm a general respiratory physician, but I also run a very severe lung disease service where I have palliative care with me. And so I often see people who say, why does nobody talk to me about my symptoms? You know, I've come to you with symptoms and you talk about a disease. So we know that there's often a bit of a mismatch, that you want us to deal with the symptoms and we're fixed on the disease, and that's actually of no help to anyone. And so sometimes people stop telling us. And we also know people go to their GPs, and perhaps the GP doesn't know much about interstitial lung disease because it's not common. So it can kind of feel like you're a bit lost in the system and that you're trying to navigate all of this, and who's going to help you? And the point is there are actually lots of people who can help you. So your respiratory physician should help deal with symptoms. Your GP can help, specialist palliative care can help. And of course, if you're doing pulmonary rehab in the community, that is actually strongly focused on symptom management. So if you don't get a good response, just keep asking and keep highlighting what your challenges are, because it is our responsibility to deal with your symptoms. So I get to talk about what's new in current symptom management, and what I'm talking about is very new in symptom management. So I'm going to show you some of the new evidence that's been published in the last couple of years regarding how we manage symptoms. So the first thing I'm just going to talk you through, and again, as Chris said, he said he didn't want to dumb down his talk, and I take the same approach. You're all highly intelligent people, and this is about educating you to know what we're currently doing. So this is the European Respiratory Society, a clinical practice guideline. The European Respiratory Society is one of the biggest international respiratory societies. It's a really important group. And I have a slight conflict of interest because I co-chaired this task force that wrote this guideline, and I co-chaired it with Anne Holland, who is a professor of respiratory physiotherapy at my university. There are a lot of Australians who are involved in this clinical practice guideline. So Tam was highlighting, we do great research in this country trying to improve the treatment of interstitial lung disease, but also symptoms. So with most clinical practice guidelines, what you do is you bring together a multidisciplinary group of experts, and that includes you guys. So we had plenty of patients involved in this guideline who told us what the priorities were and told us what the priority outcomes were in terms of thinking about what makes a difference to symptoms. And one of the things about this guideline that's a little unusual is we called it serious respiratory illness. So it's not just interstitial lung disease, it covers a variety of respiratory illnesses. But serious respiratory illness refers to illness that causes mortality, that's burdensome, and has quite challenging symptoms or has side effects related to treatments. So as I imagine none of you want to read the 250 odd pages that we wrote for this guideline or the 8 ancillary publications that are coming related to it, this, if you just wanted to know one thing, you take a look at the picture that we wrote, and I actually told my colleagues that yesterday as well, of to take a look at the picture because it tells you what we said we should do. So green means go and red means no in this diagram. So you can see there are a variety of different things that do work for symptoms, and I'm actually going to talk through these more broadly. But there is one thing that we also said that didn't work and which we now conditionally recommend against, which is opioids, and I will touch on those. So this is a hugely busy slide, which again, I don't expect you to read, but this is what I put up yesterday when I was talking to my colleagues, and I was putting it up to highlight to them, you know what, there are things we can do for symptom management. There are things we can do for breathlessness, cough, and fatigue, but we have to take this stepwise approach of finding the underlying conditions and causes, treating them, and then we step up. So let's go through some of these a bit more slowly. So I'm going to talk through breathlessness, cough, and fatigue, but not so much on fatigue because there isn't time to cover all of it. So as I have sort of hopped on a bit, and I think Chris and I were singing from the same hymn sheet, we have to work out what interstitial lung disease you have first, because we have to get the treatment of that right. But those coexisting medical problems are really important because most people with interstitial lung disease are older, and so most people have a few different things going on. Chris highlighted that some people are obese, many people will have some heart disease as well, and we need to treat all of those things. But the one that's up there that I think is really important is the psychological illness, so anxiety or depression. So most people do have that. We know that about half of people with interstitial lung disease will have some psychological illness as a consequence. People don't necessarily want to talk about it, and it's about us asking the right questions to explore that with you. Because I can tell you if we don't treat it, it often makes it impossible to treat breathlessness. So most people who see me are profoundly breathless and are terrified of their breathlessness. In fact, they become frightened of the fear, and it then impacts being able to go out. So if I don't unpick that and explore what's going on, what's happening at the moment, but actually often what's happened in the past, I can't make a difference to breathlessness. So if it feels odd that someone talks to you about other things, it's because actually it's all relevant. And the other one that's really relevant actually is sleeping poorly, which is very common in respiratory illness. And so trying to work out what is the driver for your poor sleep and what can we do about it, ideally without using medications, but often actually using something like melatonin. So in terms of those symptom-focused approaches, so these are all evidence-based approaches. These all work. So the first one is ideally to be seen in a multidisciplinary breathlessness service or a multidisciplinary integrated respiratory and palliative care service. The thing is that's, it's very easy for me to say that because I lead one of those services, but I also have done research that shows there aren't many of them, unfortunately, globally, and there aren't many in Australia. So there are some certainly in Melbourne and Sydney, but more broadly not. And that's why I certainly spend a lot of time trying to educate colleagues on how we can manage symptoms. So if you don't have a specialist breathlessness service, it doesn't mean you won't get good symptom management, but it is important to actually ask and say, is there a resource? Is there someone else who can help me if you don't feel you get it from your respiratory physician or your GP? Other things that work are breathing techniques, which I unfortunately don't have time to talk about today, but they do make a difference, and they're often taught through pulmonary rehab or through physiotherapists or ILD nurses. Facial airflow, so using a fan helps with breathlessness. There are clinical trials showing this works. And the other one is relaxation and distraction, which sounds so twee to say, you've just got to relax and, distract yourself. But actually, for some people, it's a critical strategy. If you're having a panic attack related to your breathlessness, the most important thing is to distract someone. I have people who walk into the room who are quite frightened, who start to panic, and I can talk them down simply by distracting them. So we know it works. But the thing with all these strategies, you actually have to individualize it. And I'm going to talk a little bit about that in a second. Other things we know that do make a difference are physical activity, so pulmonary rehab. But I really do believe in pulmonary rehab and it's really useful. But let's be honest, not everybody likes exercise. I personally love exercising, but you either do or you don't, right? So some people don't want to do it. So physical activity, while pulmonary rehab is important, it's actually also about what you like doing. So do something that keeps you active, that you enjoy. So if that's gardening, marvelous. If it's pulmonary rehab, bring it on. That's what we want you to do. But any activity that keeps you active, that you enjoy doing, is really important. And the other thing that really does help, which most people really don't want to have when I mention it, is a four-wheel frame. And the reason for that is actually you can usually double your exercise capacity, and we want you to stay active. But most people will say, I'm not old, I'm not using that, that's embarrassing, or have substantial stigma around using this. My father-in-law actually just died. He died of a different lung condition. He died at 87, and at 87 he wouldn't use a frame because he said he wasn't old enough. I was like, I think you do, but there you go. And the other thing that's really important is actually having a plan. So we've done research that shows having a breathlessness management plan is like having an action plan for treating infections. You have to write it down, because often when people are frightened and can't manage symptoms, it's the person who's next to you who's going to help you. It is your family member or another caregiver. So you give them the plan so they can work with you and help you to manage your breathlessness. So again, oddly enough, there is evidence that breathlessness plans make a difference to symptom management. But the whole thing with breathlessness management is individualizing it according to what the person wants and is prepared to do. So this is what's called the breathing, thinking, functioning model of breathlessness, which was developed actually by a very good friend of mine and a colleague in the UK. And this was developed about 6 years ago. And one of the reasons I put it up is because this is actually about to get updated, because one of the problems with the way the model was developed was the language was slightly negative, and now we've had loads of input from patients making it clearer we need to use more positive language. But we often use this as a tool with patients and caregivers to unpick which one of these little wheels is spinning most for you. Is it the worrying and the thinking? Is it that you're doing less and you've become a bit deconditioned? What do we need to do to target the right symptom-focused approaches for each individual? So it's not just throwing everything at everyone, it's working out what works for the individual and going through it. Now, one of the challenges I know for many people is they often don't know much about these different techniques that I've just sort of flown through, but actually many of my colleagues don't know about them. So for many years I was asked, will you share all the resources you developed? And we said, absolutely, and we wrote booklets, and then in the pandemic we'll put it all online. So we wrote this website to support patients, caregivers, and clinicians. We initially wrote it for breathlessness, but it does have information on cough and, oh my gosh, is it fatigue, I think is the other one. And it's funny because I always put this up at different talks, and I was looking at the metrics on this, and we've now found that it's being used by 12,000 people in 78 different countries. So I think it's helpful, but then I wrote it, so I'm slightly biased. But this gives you the idea about what we talk about in those symptom management approaches. Now, I want to talk about a couple of things that don't work. So oxygen works if you have low oxygen levels at rest, right? The reason we prescribe that is because there is a survival advantage. So if your oxygen levels at rest are low, and we can show that at least a couple of times, we will prescribe oxygen, because actually what we're trying to do is protect the right side of your heart. So that's why we give oxygen. It has nothing to do with symptoms. We're prescribing for a survival advantage, and unfortunately that data comes from people with chronic obstructive pulmonary disease. And obviously if your oxygen saturations DSAT fall when you're walking, we will also give you portable oxygen therapy. If you have symptoms and you have normal oxygen saturations, you will not be prescribed oxygen, and there's a very good reason for that, and that's that it doesn't work. Okay? So it may help your breathlessness if you've got very low oxygen levels and need it. If you don't have low oxygen levels, it does not help with breathlessness, and there is very good clinical trial data that shows that. And actually that kind of makes sense, because breathlessness is not just due to low oxygen levels. If you were anemic, you would be profoundly breathless, but you wouldn't need oxygen. If you've lost muscle mass, or if you're overweight, you're profoundly breathless, but we wouldn't give you oxygen. So oxygen generally doesn't work in people who have normal oxygen levels. And the other thing with it is there are serious risks associated with it. So I ran the oxygen service at the Royal Melbourne Hospital for 10 years. I saw people who fell over and ended up with hip fractures related to oxygen. I saw someone who decided he would smoke on oxygen and ended up in the burns unit. So again, there are problems with oxygen, which is why we treat it as a drug and prescribe it and give it to people who have low oxygen levels. It may help with breathlessness. If it does in that scenario, that's marvelous. If it doesn't, that's sad. And for most people, it will not make a difference. So we don't recommend for it. The other thing I want to talk about is opioids. And for many years, I have prescribed opioids. So running an integrated respiratory and palliative care service, I've probably prescribed more opioids than many of my colleagues. But this clinical practice guideline that we did, so we brought all the opioids evidence together to look at whether it works. And that has now changed my practice. So we brought together lots of clinical trials, but sadly only one of those clinical trials is in people with interstitial lung disease, and there were 36 people in that trial. So we don't have great evidence in interstitial lung disease. But what we found when we brought all that clinical trial evidence together is opioids don't work. So they don't actually help with breathlessness for most people with respiratory illness. And there are two types of trials. There are trials where they've given 1 or 2 doses of an opioid and then given someone an exercise test, or given people opioids for 1 to 6 weeks. And when we bring it together, we see they make no difference to breathlessness in daily life where it's being prescribed regularly. They don't improve quality of life either, and unfortunately have very serious side effects. So what we see is a lot of nausea, vomiting, constipation, and drowsiness. So the nausea and vomiting is not great if you've already got side effects related to your treatment. Constipation is not great, because I know that when I've had patients become constipated, if I push your diaphragm up because you're so constipated, then I'll make your breathlessness worse. So side effects actually really matter. And in one of those studies that we put together for the brought together for that clinical practice guideline, which was COPD, so it was not people with interstitial lung disease, they had a third of patients had very serious side effects. So actually that's really changed practice, certainly for me. So I've never found it actually particularly helpful for people with interstitial lung disease. But now we do have evidence that actually, when you bring these trials together, it doesn't really work for breathlessness. So we're kind of making a shift against this. Added to which, we know that many people with respiratory illness and other illnesses actually don't like opioids. So most people, when I've suggested it in the past, have kind of said to me, but I'm not dying, and I don't want to take this drug. And then I won't be able to drive. And that is actually quite relevant. You have to be able to think about whether someone can drive. So we know that many people don't want to take them anyway. But what I want to really make clear is that evidence that we brought together for the clinical practice guideline really does not have enough data for people with interstitial lung disease. But from my own clinical practice over many years, I don't find it particularly helpful for breathlessness and interstitial lung disease. I do find it helpful for cough, but not for breathlessness. And the other thing I want to stress is we are talking about opioids over the last few years of life. I'm not talking about end-of-life care. So when someone is right at the end of life, we do think opioids work, but that's a very evidence-free zone. My slides have been changed in colour. So this said red, this was red before, so this was a recommendation again, so that's what we said. So coming back to that, that table that I showed you at the beginning, we're going to move to cough, and you can still see there are things that we can do for cough. So what works is, again, to work out the interstitial lung disease and treat it, and actually that really matters in cough because the drivers of cough vary according to what your interstitial lung disease is. So for example, if you've got idiopathic pulmonary fibrosis, we know that sometimes pirfenidone can reduce cough frequency. If you've got a connective tissue disease like Sjogren's syndrome, where there's a lot of dryness and dryness of the airway, sometimes strategies to reduce that dryness using saline nebs can be very helpful. If you've got hypersensitivity pneumonitis, if I give you prednisolone and we try and avoid the trigger for it, actually often your cough will completely disappear. So knowing your interstitial lung disease type really matters for cough, not so much for breathlessness. And again, treating all those other coexisting medical problems matters. So if someone is smoking, dealing with medication side effects, because some medications make cough worse, dealing with sinus disease, all of these things matter to try and reduce the frequency of cough. When we've done all those things and someone is still coughing, the approach that we would often then say is, right, I'm going to refer you to a speech and language therapist to teach some different strategies to manage cough, to help people to cope with it. So some of those are cough suppression strategies, and some of them are around laryngeal hydration. So we know that once people start coughing, it can be quite difficult. It just starts to get worse and worse and you get stuck in that vicious cycle. And so we often really focus on hydration strategies. But again, it doesn't work for everybody, so it's quite challenging. So having just told you that the evidence is against opioids for breathlessness, I'm now going to tell you something different for cough. Yeah. So for cough, what we know is that there have been 2 recent clinical trials that have published in the last 12 months. And they're both very small trials. So they only had sort of 38 to 43 people. They gave different types of opioids. One gave a very low dose at 5 milligrams twice a day, and the other one gives nalbuphine, which is like morphine. And they gave a massive dose because they give 162 milligrams twice a day. These are both short-term clinical trials for 2 to 3 weeks, okay? And what they found was there was a significant reduction in cough frequency of between 39 and 53%. So we can definitely see that it works. But again, what they found was there were definitely serious side effects. And in that nalbuphine trial where they were giving quite high doses, a quarter of people had to stop treatment because of side effects. So what we know now is that, yes, opioids do appear to work for cough and interstitial lung disease. I would certainly agree with that. That's been my experience clinically. But there are side effects in play, so it's that benefit versus risk. And what we don't have is long-term data. So this is 3 weeks of data. And from clinical experience, once someone is on an opioid cough, you can never get them off. It is very, very difficult. So that means you're on it for the rest of your life, usually. So for other symptoms, I'm just going to quickly go through and say for fatigue, we don't have many great treatments, but what we do tend to focus on is exercise and physical activity. And as I was saying before, that physical activity is whatever you want it to be. So if I tell you you have to do pulmonary rehab and you're kind of looking like, I can't do that, you must be nuts. Do something that you enjoy to stay physically active, because actually the evidence is it does help with fatigue. The other one is appetite, which I just want to talk about very briefly, and that is to say that poor appetite is very common, particularly when you have severe disease. And often the partner will come in and say, I'm trying to make so-and-so eat more, you know, it's really important. Actually, all we want to do is make sure somebody doesn't lose weight. So often if you're less active, it's a bit like a car. If you don't drive it, you don't necessarily feel the desire to refuel it. So I often say to people, you know, yes, it's important to maintain weight, but not at the expense of nagging someone to death or making someone take supplements they don't like. So it is about maintaining quality of life and ideally maintaining weight, but not driving people to do something they don't want to do. And the other thing briefly was those treatment side effects are really important, and it is our responsibility to deal with them. So if you have them, bring it up with your treating physician, because there are things we can do like dose adjustments. So I have 2 more things I want to talk about, Amanda. And Chris mentioned this as well. Supportive and palliative care is really important. As Chris was stealing my thunder about, it is not prognostically related. It is actually just about good clinical care in the last few years of life. So it's given together with disease-directed care. It is not one or t'other. They are usually given together, and it doesn't have to be given by specialist palliative care. It can be a GP they're often really skilled in palliative care. So it can be your respiratory physician. So supportive care can happen from anyone, and it generally really does make a difference to physical symptoms and psychosocial symptoms. So I'm just going to briefly tell you what's next in symptom management. So lots of people don't like exercising, and singing for breathing programs have existed in the UK for more than 20 years. We do not currently have a singing for breathing program in this country, but I have just been doing a clinical trial where we did singing for breathing for people with COPD and ILD. We've just done the largest trial in the sense of the largest one that's included the most patients with ILD. We need 2 more patients, and then we will stop recruitment, which will probably be next week. So watch this space, because we do think it's actually very useful for symptom management. It's a great way to teach breathlessness management and control. So I can't show you the clinical trial results because I don't have them, but one of my PhD students, we did some qualitative research with interviews, and we also did what's called ethnography, where you watch what's happening. And we found it was really helpful. So what we heard in that research was actually, it really helped with getting mastery for symptom management. It really helped with peer connection and support with others. And it gave people something that was just joyful and uplifting. And people often chose music that gave them happy memories from the past. So actually things that are fun, you can't stop doing them. You've got to do things that are really useful. So we think this is going to be helpful. Infinite is another clinical trial that I'm leading, which is looking at something called domiciliary nasal high flow. So nasal high flow therapy, if you've ever been really sick and in hospital, we'll give you oxygen, and we'll usually give it through a high flow system with humidification and heat. And the reason we use that is because actually you get better outcomes. But there is some data from other illnesses that if we use nasal high flow at home long term, it can actually improve symptoms. And so what we think is it'll probably improve things like breathlessness and cough. And I have given this to a few people outside of trial, and it's helped. So that's why we're taking it to trial at the moment. So we've just started recruitment for that trial, and we're doing some quite sophisticated other things related to it. So what I would say is that it's been a very evidence-free zone over some time, but there is research that's going on. We do have things that we can do to help with symptom management. Please do remember to, if you feel ignored, just keep asking, because there generally is somebody who can help you with your symptoms, and hopefully we'll have some new treatments in the future. So thank you.
Thank you, Natasha. Not just insightful, but wow. I just wish I could take you home to my place and, just take you around to a few of my specialists just for a month.
My children might not like that. But...
We live in a nice spot. We have some time for questions now, and any online, Tara's going to let me know. So again, pop up your hand. We have a roving mic, but I'll just read this one. My O2 is okay at rest, but rapidly drops at movement. Would O2 therapy assist me in exercise as my fitness is declining due to my O2 dropping rapidly during exercise?
So it's definitely something to talk about with your treating respiratory physician regarding whether you need oxygen. Oddly enough, it actually varies state by state, and I'm in Victoria and we're allowed to prescribe portable oxygen therapy, but it's not necessarily the case for all states. So, and by portable oxygen therapy, I'm talking about that you haven't got a concentrator at home, because if you have got a concentrator and need oxygen, you get portable oxygen therapy usually automatically, or it's certainly in my state. Portable oxygen therapy is just where we give someone oxygen when their levels fall, so they desaturate. But again, we don't usually, we'll only prescribe it if somebody walks further. So it's not what happens to your oxygen saturations, you have to walk further. So we do the first test on air, and then we do the second test on oxygen. And so if somebody walks further on the second test, we prescribe oxygen because we're trying to improve exercise capacity. So the answer to that question is it's not about the oxygen saturations per se, it is about trying to improve someone's exercise capacity. But what I would say to that person is, talk to your respiratory physician and make sure you're doing exercise tests like a 6-minute walk test regularly so that we can work out whether you need oxygen or not.
Thank you, gentlemen.
I just wanted to make a comment on 2 points. For the exercise, I found a physiotherapist who specialised in lung disorders. That was incredibly helpful. And just coincidentally, in terms of anxiety management, about the same time I got diagnosed, I started to attend Buddhist meditation classes, and that really helped.
And I think they're 2 really, really important points, right? Because, again, sometimes in Australia it can be really difficult to find pulmonary rehab programs. And if you haven't got access to that, having someone who is skilled, and it really is a skilled respiratory physiotherapist, because I agree with you, because sometimes if you go and see a physio who does more musculoskeletal, you won't get the support you need. So you need a skilled respiratory physio, and I completely agree, because I have a go-to person in Melbourne that I refer all my patients to. And the other thing that you said that was so lovely is around finding something that works for you to deal with psychological distress. So there is no one size fits all. It's whatever you want to engage with. And if it works, brilliant. That's really important. So if you found something and it works, good, that's great. I love it when people tell me things like that. It's really important.
Thanks, Natasha. Great work. I diagnosed back in 2003, which is quite a long time. I've done a lot of running in my life, and I still try to keep running as much as I can. 150 meters at a time nowadays. But the thing I get from my specialist is, you're doing remarkably well, Clark. And that's about as far as it goes. So I got tired of that. I dug up all my eye care data medically, and I drew a graph. And the graph shows my DRCO has dropped off by 30%, and my lung capacity's dropped off by the same amount. I'm wondering if I can get anything a little more helpful from my specialist rather than you're doing extremely well.
Yeah, that's challenging, isn't it? It's funny actually, because I often have patients who have quite a lot of heart disease as well as their lung disease. And they always come in and say, my heart's fine. My cardiologist says my heart's fine. I'm like, your heart is so not fine, and it's so contributing. So it's often, it's always like there's a double entendre in what's said, that we're kind of going, oh yeah, you're all right, because you're kind of still here and symptoms are okay. And actually it's sometimes it's false reassurance. I agree that you're watching someone on a glide path that's getting worse, but you don't want to take away hope and all these things. So sometimes I think the way we communicate is not good enough in terms of, you're fine, you're good today, but actually we know that things are progressing. And again, if you feel that you get that frustration, turn around and say, I want to know more, and again, this is really important. This is why we have sessions like this, because we want you all to be the experts in your illness. You are, you live with it, not me. And that's why it's really important to be empowered. And, for some people, tracking their lung function is really helpful. For others, I find that it makes their anxiety worse. So again, it's about what works for each person. But, you know, it's really important if you have got that information. I love it when people bring me plastic folders full of information because it tells me how connected they are with their illness and can really talk to me and work with me. And I think it's important that you turn around and say, look, this worries me. You know, you're telling me everything's fine, but what does that actually mean? What does the future hold? So do turn around. If you feel you don't get the answers, you know, go back and ask for more. And the other thing to say is sometimes one specialist doesn't work for everybody. So sometimes you end up seeing another person and you get another opinion, and, you know, that sometimes can help. So you don't have to feel constrained with just, I'm just going to ask this person. Sometimes you can get a range of opinions that can help.
Is it within reason for me to ask of this specialist, at what point on this graph am I going to have to start looking at support?
Yeah, of course. Absolutely. You should always ask that question, even at the start. So I look up to people with, you know, early stage pulmonary fibrosis as well as late stage. And so even in early stage, I'm often, when I'm explaining the diagnosis, we were having these conversations about what do I think the future looks like? And as Chris highlighted, it's often actually difficult at the start because you're waiting to see someone's trajectory, and you've had an amazing trajectory because you've been here for so long. And I've got people who've lived for 17 years too. It's not common, but I've certainly seen it. But it's always okay, even at the start at diagnosis, to say, look, what do you think is going to happen? You know, what kind of support am I going to need and how will I get it? So you can ask at any stage in your illness. You know, that's part of a good therapeutic relationship is you ask us and we should listen.
Okay, well, I'll have to be a little more forceful.
Just say Natasha said it.
Right. There's the graph. Where am I?
So, just to elaborate, pardon me, Natasha, on what that gentleman said and what you said at the end before he asked his second question. I started off with a specialist, a lung specialist, who I didn't feel comfortable with. And I wasn't sure, so I took my wife along just to get an opinion of her from about this gentleman, and she agreed, and she said, Keith, you need to do something about that. And I suggest to that gentleman who just spoke, it's our illness, it's our body, it's our life, it's our condition. Don't be afraid to walk and go to another specialist. Just like if you weren't happy with the mechanic that was looking after your car, you would go to someone else. And I think, you know, we need to be all aware that it's our prerogative, if not our duty to ourselves and to our family and to our loved ones, that we make sure that we're getting the right advice. And I'm far more happy today than I was with the previous one, because I'm getting that advice that I need. And I think that's important. So I encourage you to pick up your file or ask for it to be sent to another doctor. But again, there you need to do some research, right, to make sure that you get someone that will meet your needs. See, we are, and I say that, no, I say that with respect, but I've met a few older people who, and I understand that, who in my lifetime I've come across and they said, oh, you know, the doctor said so and so. And I said, well, do you think that's the right advice? And they said, I don't know. I said, well, go and ask someone else. Don't be afraid. Oh, yeah, but we've always been with this doctor. I said, listen, don't worry about that. Go to someone else. You can always come back, but get a second opinion. Make yourself feel comfortable in your own decisions.
Thanks, Keith. We've just got one final question here. If we can make it quick, we're just a little bit over time.
Thank you, Natasha. With the high incidence of gastritis and apnea, I was wondering how important controlling those two things are with this disease.
So by gastritis, do you mean gastroesophageal reflux, or do you mean side effects related to antifibrotic therapy?
No, the reflux.
The reflux, yeah. As Chris alluded to, the school of thinking changed regarding reflux. So, 22 years ago when I was at the Brompton, we just automatically treated everybody with reflux and pulmonary fibrosis, right? Like, because we kind of really thought it was a driver. And these days, our clinical practice guidelines would say, don't treat automatically, treat if the person is symptomatic. And there's kind of good reason for that, because you're putting somebody on a treatment that may not make much difference, and they may get side effects from that treatment as well. So generally, if someone is symptomatic, I will treat, and particularly if someone is symptomatic and coughing, I will treat, but I wouldn't just put someone on gastroesophageal reflux medication without it, without symptoms. And the other thing with symptoms is anti-reflux medication just generally reduces the acidity. It doesn't necessarily mechanically stop you refluxing. So often what we do talk a lot about is changing lifestyle factors. So you often actually reduce portion size. You try to stop someone eating it, after a certain time at night, which is a bit miserable, right? Like if I tell you have to eat at 4 o'clock in the afternoon, that's not a great thing to be told. And the other one is actually elevating the head of the bed. So we often will talk about non-drug strategies first for managing reflux, and if that doesn't work, then add in treatment. So, but it is quite mixed. Most physicians will vary according to whether they think they should treat or not.
Thank you. Thanks everyone for questions. I know there were a few that didn't get them, but we'll try and answer throughout the day. Thank you again, Natasha. Great presentation. Please help me thanking Natasha.